This presentation will address all the throughput efficiencies that we believe will be able with using the LEO technologies that was designed specifically for upright radiation therapy treatments. We will start talking about what's different from the past. Is there any clinical evidence of any workflow benefits? Do we have any technical evidence of workflow benefits? And then we'll talk about some remaining challenges. What is the stuff that we still need to work on, that we're still uncertain about, and we will not make any definitive claims about yet. When we talk about upright treatments and talk about efficiency, we have to think about historical systems, and a lot of people might have heard that historical seated treatments were often inefficient in positioning the patient. People say it takes a long time. People say upright treatments take longer than supine treatments. But here's a couple of aspects that we will walk through. And it's true that current and historical systems used for upright treatments was really basically designed for supine treatments. And so the positioning image guidance systems that they used to set the patient up had to be adapted from stuff that was designed for supine treatments. Typically a chair is added to a robotic arm designed to carry a tabletop. And I was part of many of these designs. The system that's currently used in Chicago is one of those examples. I'll show a picture of that in a minute. And the main big problem is that the chair cannot rotate through 360 degrees about a vertical axis. So what we see here is the system that I designed while at Procure. You can see on the left here the part of the robotic arm, and then a cantilever system that carries the chair. In the middle picture here, you can see how the system attaches to the articulated robot arm, and on the right you can see the patient now in a position for intracranial treatment. But the problem is that if you want to change that beam angle and come completely from the other direction, you actually have to disconnect the chair basically from that locked position and rotate the robotic arm. And it works, but it's really a suboptimal system in terms of a slick movement between beams. Now, once you start having to do that and start moving the patient around a lot to get from the one orientation to the other orientation because of the limitations of positioner, we do see the risk of patient posture changes during the seated treatments become significant. Imaging procedures in these old systems often have been sluggish and inefficient, which then leads to the patient not being very comfortable. And I must say that patient comfort was not really addressed adequately in historical systems. And one such thing was the lack of a knee support or a shin support that then allows the patient to slouch down. And as soon as the patient slouches down a little bit, then of course that would change the altitude of the patient. Another big thing of historical systems is the absence of 3D volumetric imaging at isocenter. So upright 3D imaging solutions are typically at a distance away from the isocenter, so-called in-room CT, and that's also the case for the upright CT scanner in Chicago. A 3D imaging system that is away from isocenter can typically not be used for patient positioning due to the mechanical deflections of the PPS. So if you have to transfer the patient to the other side of the room, these mechanical arms always have significant deflection as the center of gravity moves further away from the mounting point. And also moving a patient over large distance can cause changes in the patient's position while immobilized. And that's of course due to acceleration and acceleration forces, inertia, and rotational forces on the patient during the movement. So really these off-isocenter 3D imaging systems that's been installed in many rooms, the so-called in-room CT images, really there for quality assurance purposes. And I just talked to the folks at the Mayo Clinic in Rochester the other day. They're actually using their in-room CT scanners to image the patient after the patient had gone through the treatment. And so that really just replaces the idea that the patient has to walk down the aisle and go lie down in a normal CT scanner for a QA CT scan. So what is really different from the past? And what I present here today to you is the LEO cancer care approach, where we started absolutely from scratch with nothing specific in mind other than finding, first of all, a comfortable position for the patient to be positioned in the upright position, and then we wrapped a CT scan around it. So here's a photograph of the patient positioner. It's a 3D CAD rendering of the patient sitting in the patient positioner, and then the CT scanner that come down around the patient and do the axial dual energy CT scan of the patient in that position. So Leo has basically three products. It's the ADA system, which is a pure diagnostic dual energy upright CT scanner, the EVE system, which is the patient positioner, and then Marie, which is a combination of the CT scanner and patient positioner designed for putting in front of any treatment beam to do full image guidance at isocenter based on axial CT. So we are designing this to really overcome the historical shortcomings. And what is the main key features of the system that I'm presenting about right now that I believe will result in a much better workflow and a much more efficient system? So first of all, we start with a very comprehensive software and workflow control system. We really focus extremely hard on patient comfort. We introduced a heel and a shin support system to make sure the patient can't slouch down. We install a dual energy CT for fast helical scanning and proton radiography at isocenter. That's really important, that we will be the first solution right now that bring dual energy CT at isocenter to the proton therapy camp. We also add 3D optical guidance and motion monitoring. So we'll have a slide showing how we're implementing the 3D optical guidance. We spend a lot of time to make very accurate and optimize the PPS movements about isocenter. We really want to make sure that once we scan the patient, we have the minimum amount of motion required to drive the patient to treatment isocenter. Then we're also working on future developments, and a good example of that is the prompt PET and upright PET CT. We have plenty of space around the patient to install PET panels, and will allow us to do the 10 millisecond half-life isotopes readout. The system should be able to accommodate proton arc therapy, flash, and grid by just replacing the beam delivery nozzle to do these things. And eventually, once we can do the proton radiography fast enough, we can rotate the patient and do a proton CT. The comprehensive control system is shown on this graph here, and everything in the gray ellipse there is the software that Cozy Lab is developing for us, and this software will have very unique interfaces to allow many various forms of patient alignment systems to feed into the comprehensive control software that will then talk to our Leo EVE and Marie CT scanner and positioning system. There will also be an opening for future inventions if somebody comes up with a better way, because we know upright therapy will allow us to come with new technologies to do the patient positioning better. And all this control software will allow for the therapist to control the entire positioning process out of one single graphic user interface. So this slide shows the installation of our optical tracking system that we're developing ourselves with a company in Knoxville. You can see on the left picture here is just a graphic illustration of the mounting position of one camera at the isocenter level, and we can see how we can see a beautiful unobstructed view of the patient in that direction. Then we can mount 4 cameras in a similar position as indicated there, with positions 1, 2, 3, and 4, and even a 5th camera from the top. Important to note that these cameras are exactly 90 degrees apart. So we end up with a complete orthogonal system, and the beautiful thing is that if the patient would, for example, facing directly into one of the cameras by rotating the positioner through 45 degrees, the other camera will see the patient exactly from the side. So if you show those images to the patient or to the therapist, it should be very easy to align the patient left, right, or forward, backward at any specific moment. So when it comes to the question whether we have clinical evidence that upright would have some workflow advantages, this slide talks about data represented in a paper from Yang under the leadership of Lawrence Court, where they looked at the lung volume of patients in the upright versus the supine position. In panel A, we can see a coronal cut through an upright MRI scan of a volunteer human versus that same person in the supine position shown in panel B. We can see that this study discussed the scanning of about 5 volunteers, supine and upright, and they found that the maximum difference in volume was up to 50% larger, the lung volume being 50% larger in upright position, but on average the lung volume was 25% larger under the people studied. They found that the average reduction in the superior to inferior excursion of the lung diaphragm edge was up to 4 millimeters smaller in the upright position. That means that if we see a reduction in lung excursion, there's going to be a reduction in the need to do motion management, because the AAPM task group specify that one need to do motion management if the excursion is more than 5 millimeters. So we believe that in an upright position, the need for motion management is going to be vastly reduced. The next paper that I want to highlight here in terms of evidence, clinical evidence that upright will improve the workflow, is again another paper under the leadership of Lawrence Cord by McCarroll, where they added a seated chair type device to a Linac couch, and in this case they studied 5 patients that were under treatment with x-rays in the supine position, but they had IRB approval to also do x-ray imaging of the patients in upright position. So they did not treat the patients in upright position, but they went through the entire process of immobilizing the patient upright position in this unique device. They then had the patients filling in the questionnaires, and here's the data on 6 criteria they studied, and we can see that in 4 out of the 6 criteria the patients voted in favor of the upright position. And the other ones was marginally the same. So we know that we can actually have patients comfortably in upright position, which means that if the patient is more comfortable in upright position, there will be less involuntary movement that will improve the throughput. One classical scenario here in the upright position is the need to swallow and the movement of the vertebral part of the body, the neck, as the patient have to keep on swallowing in a supine position. We know there's a lot of vertebral body movement as a result of swallowing, and that certainly is reduced. If that is reduced, throughput will be improved. A third paper we want to discuss today is the paper studied by the group in PSI by von Siebenthal. They looked at liver drift, and what they found is that if the liver, if you move the patient from a supine to an upright position, actually I misspoke, from an upright position to the supine position for treatment, then the liver keep on drifting over a 35-minute window and up to 20 millimeters. So that just means that if we change the gravitational forces on the patient's abdominal structures, meaning that the patient spend most of the time driving to work in an upright position, seated in a chair, waiting for treatment, all in upright position, then go lie down, then these organs will systematically keep on drifting, which means we might have to reposition a couple of times. The next clinical data, clinical evidence of workflow improvements that we're going to present is our own work on prostate position and the pelvic organs in the supine versus upright position. What is presented here is just the situation of the prostate position and shape and size for a full versus empty bladder. And we can see in this case here, this is an upright position, a case where for one volunteer was scanned in an upright position with completely full and a completely empty bladder. And we can see the prostate position did not shift as a result of bladder flow. One other conclusion that came out of this study is that the distance between the bladder and the sacrum was actually larger in the supine position than in the upright position. The explanation for that is that in the upright position, the patient's abdominal content is pushing down onto the bladder, onto the prostate, and we believe the prostate is going to be much better anchored in the upright position versus the supine position. That means faster treatments, because we don't really have to wait for the bladder to reach a certain reproducible full level, which is currently a huge waste of time with prostate treatment in the supine position. We often have to use ultrasound scans to verify the bladder position. So we believe prostate treatment in the upright position can be managed with a half full bladder, and there will be less risk of small bowel encroaching onto the prostate. Now, In summary now, if we look at all these benefits that we just discussed, I prepared this slide here to summarize all the findings. So we're talking about the upright positioner showed in the upper position here, and then with the CT scan wrapped around it. And as we go through the different technical aspects that will impact benefit workflow and benefit the workflow, then the first aspect we discuss is the fact that we are going to add optical guidance as discussed earlier. And these optical guidance cameras will be isocentrically mounted to verify the patient's external anatomy. That will allow us, because we're not going to start imaging until we know we optically align, will allow us smaller setup corrections, will even allow us to have the patient participate in the setup process, and it will really obviate unnecessary imaging. Because if you know that the patient didn't move from the previous recorded position, then we know we don't have to image again. Of course, that means we assume there's no internal organ motions. The fact we do all the image guidance at isocenter means we always going to have very small movements to isocenter, which means there's going to be less deflection of the patient positioner, and there's definitely going to be a reduced risk of unwanted motion while we're moving to the treatment position. The next aspect that I think will have a huge impact on the workflow is the easier egress and ingress. It's so much easier to get in and out of the patient position, and you also have this space around the patient positioner, space around the upright PPS. We'll be able to install the immobilization devices faster, as we talked earlier, and the elimination of gravitational forces, the change of these forces on abdominal structures and organs will result in a more reproducible positioning. The organ drift, as we discussed in the previous slide, if there's less organ drift, means there's no need for repositioning during the treatment. Improved breathing will mean there's less lung motion, and there's a reduced need for motion management, and we'll be able to do a better breath hold. Easier to install immobilization devices because the therapist can now work at their comfort or height level, and no need to jump on stepping stools to get above the patient to see the lasers, for example. And we know that patients tolerate the face masks better when they're in an upright position. Use of gravity in the setting up the patient is important, because we will always have the patient leaning forward or leaning backwards. That will force the patients under their own gravitational weight into the immobilization devices. Better stability of pelvic organs, as discussed, reduced need for swallowing for head and neck cases, and then the less risk of aspiration of stomach contents, of asphyxiation. Lastly, in summary again, upright position is just much more common to the patient. Patients spend in upright position most of the day. Easy to adjust to the treatment position. We don't have to have the patient first sit up again and then slowly go into the lying supine position to equilibrate the blood pressures. And also in upright position, the patient is definitely much more aware of the surroundings. One other aspect of upright imaging is something that we realized. If we scan a patient supine, as we see in this slide, there's actually 8 different combinations that we can scan the patient in. Feet first supine, head first supine, and all the combinations. But if we scan the patient in an upright position, there's really only one orientation that we can scan the patient in. That means there's less options to scan the patient, there's less that can go wrong, and less confusion in the CT scanning process. That will definitely have a significant impact on the CT scanning workflow. This slide talks about this efficiency of getting the patient in the treatment position. And if you look at this little stickman cartoon, and I start moving the video, then we can say on the left hand side the patient is going to be treated in a supine position, and on the right hand side the patient is going to be in a seated position. We can see the first step in both processes is the patient sitting down. But on the left side, the patient now needs to be aided by 2 therapists to go into the lying position. That takes time, and only then the immobilization devices can be installed. On the right side, the patient is ready immediately. The beam can come on, and when the patient is done treatment, the same thing happens. The patient on the right is ready to exit the room, while the patient on the left still need to be helped into a seated position before the patient can exit the room. So it's obvious, like looking just at this simple parameter, that the first step in seated treatments is the final step for setting the patient up. But this is just the first step to go into a supine position. Here is then data from a group in Japan, the Keio University School of Medicine, that developed an upright CT scanner. You can see on the left panel there the patient in a seated position, on the right panel the patient is simply standing up. And they did a time study to show on the left panel that the time to get in and out of the scanner is reduced significantly, at least half the time to treat the patient and to scan the patient in an upright position versus in the supine position, while the time we take to make the scan, that is the time that the scanning ring moves over the patient, was exactly the same. We believe the same will apply to upright treatments. Here's a time study that I put together and looking at all the different aspects of the patient going through the treatment. And you can see if you look at two aspects, the making the patient comfortable and ready to receive the immobilization device and get into the immobilized state, that is what I show you with the two green ellipses. That is significantly reduced because we know the patient will just sit down and can receive the immobilization devices. The second one, where I think we'll have a significant time saving, is to verify the patient's position with the optical tracking system. Since our system is completely dependent on verifying the patient's position with the optical tracking, we believe we'll save a lot of time by making that part work. So in summary, if we just look at those three aspects, then for a single treatment room where you treat the patient in a supine position and a gantry versus treating the patient in an upright position and using the lever technologies, we believe right there we'll save up to 6.5 minutes for a single field. Now, the center part indicated there in the middle, that is common. That part reproduces for every beam, and so the savings for different beams will be coming from the fact that we have the patient completely under optical guidance, and we can simply move to the next field without spending a lot of time having to re-image. One of the things that is very apparent also for upright treatments, and we talk about non-ambulatory patients, specifically at paraplegic patients. So if you look at a patient in a wheelchair and then have to get the patient onto a treatment couch in the lying position, this is quite a complex process. It's not easy. The patient will have to be lifted out of the wheelchair onto the couch. But if you look at getting the patient into a upright treatment position, as shown here in the bottom slide, that is very, very similar to moving a patient from a wheelchair into a car seat, for example, which is common practice. So we believe that treating paraplegic patients in upright position will be much faster and easier in supine. So that is another aspect of workflow improvement. So in summary, we believe that several anatomical benefits of upright position will improve the patient position and workflow, and improve patient comfort will definitely improve the patient setup and reduce motion. So that is summarizing these two main categories. And then of course the anatomical benefits, as we discussed, is the increased lung volume, the better positioning of pelvic organs, and the less abdominal drift. And on the second category, we talk about patients with pulmonary problems that cannot really lie down, patients with neck pain, and patients with claustrophobia problems that cannot really tolerate the face masks. So now, the last part of the talk, we just want to say not everything is easy or has been resolved. So what are some of the remaining challenges? First one I'm going to present to you is the lack of high Tesla upright MRI scanners. Many MRI scanners exist, but they're all 0.5, 0.6 Tesla and even 0.2 Tesla scanners. So we don't have a solution right now for the high Tesla MRI scanners. And we are busy working on the formal registration studies to investigate this. Clearly what we believe is if we have a high Tesla supine MRI, if we fuse that to a high resolution supine CT, then take the supine CT to the upright high resolution upright CT, we should be able to translate and find the organ positions in that way. It's not a definitive statement. We need to continue to work on that, and there will be a couple of outliers. We are busy analyzing that, and we can present this data within a near future. We still need to do more work on the anatomical data in upright position. There's simply just not enough data available at the moment, and so we are continuing with the prostate study, adding more volunteers to that study to study that. Anesthesia or sedation for patients in the upright position, we still need to develop special immobilization devices. We don't believe it's a massive problem because anesthetizing patients in the upright position is common practice. Two examples are posterior fossa and shoulder surgeries. Another one is what about non-ambulatory patients? We need to develop solutions for treating quadriplegic and bedridden patients in the upright position. We believe paraplegic patients that's already wheelchair bound probably not be a big problem, but patients that's bedridden and quadriplegic would need some more work. Another aspect we need to work on is immobilization devices, and one specific aspect is breast immobilization. When we treat the breast with x-rays, we need to develop techniques to pull the breast off the chest wall in the forward-leaning position. But for very more patients with spindleless breast, we know that even then the breast will be sitting onto the belly, and we need to develop techniques to keep the breast off the belly. In the case of protons, we need to develop a technique to push the breast onto the chest wall. We are working on this. Here is a breast shell, and here is the breast shell attached to a, in this case, a male person, just to show the concept. But if you make these breast orthopedic shells per the specific patient's anatomy, these are patient-specific shells, you attach it to the chest and then immobilize the patient, we believe we'll be able to squeeze the breast into a very reproducible position that will make actually breast treatments very accurate. We need to work on optimize the room configurations. What image guidance techniques do we need in the specific rooms? Do we need everything in every room? That means proton CT, proton radiography, prompt gamma, or can some rooms be equipped with the dual energy CT and maybe or cone beam CT? That stuff we need to work on. One question that always comes up is, what is the ideal arm position? We need to study the arm positions for the different disease sites. And we need to develop the ultimate integrated software and decision-making solutions. How do we deal with all the additional information that we will have? Will the ability to adapt on the fly slow us down if you suddenly have all these decisions to make and suddenly have all these information? Will that now slow us down? And yes, maybe it will be, and that's why we doing our financial optimization to a little bit of a less throughput in the first year or two as we figure out all these unknowns. When is adaptation really necessary? That would be another question that we will have to answer soon. So in summary, I used to say that the only problem with protons is the lack of protons. The more proton sensors we get, the more we would need. And I think now we can, similarly to this, we can say the only problem with upright treatment is that we don't have an operating facility yet. As soon as we have it, we all will want it. So with that, I want to say thank you. And I would appreciate any feedback on this presentation.